Let me please reintroduce Barbara. Franz did that, but let me do it properly. Barbara has Crohn's disease.
When you have Crohn's disease, it's not just about running to the bathroom. It's about the pain. It's about blood loss. It's about humiliation. It's amazing how much it impacts everything in your life. I don't think I've let Crohn's hold me back as much as most people would think. I've had children. I've had a successful marriage. I've kind of tried to always stay positive. I think I pull back a little bit, but I don't think I've ever let it truly stop me. I've always been a fighter, and I'm not going to let Crohn's just stop me from doing things. A bad day is waking up and knowing at 5 o'clock in the morning that you're going to have to start your medication. A bad day is in the bathroom, doubled over in pain, probably 20 times a day, 30 times a day, until you're just so exhausted you don't know what else to do. That's a bad day. A good day is a day that I could wake up and not think about the Crohn's disease. A good day is going to the park and not having to worry about a bathroom. A good day is going to the supermarket and making it through a whole food shopping without looking for a bathroom. A good day is pain-free.
So, 4 years ago, we decided to pull some experts together across Europe and try to find ways to use technologies, computers, to help Barbara, to help her have more good days than bad days, or at least when she has bad days, to be able to predict that and adapt her life. So what we wanted to do, and that was our vision, was to develop an automated technique for Barbara to assess her disease, a bit like a thermometer for Crohn's disease. It had to be non-invasive, like a thermometer. And it had to be a way to give an accurate score of the disease. So this is what we wanted to do. We wanted to derive a score, a number, very important, non-invasive. We don't want to make her suffer more, in order for her to manage her disease better. So this is what we wanted to do. We started this process 3.5 years ago. And you might ask, where exactly are we now? Well, we are not there yet. What we have now is a very strong foundation upon which we can build further. And this is what I would like to demonstrate to you today, our foundation for this project. So let's start. Let's introduce the patient. I would like to please ask Professor Stuart Taylor, Professor of Radiology from UCL, to tell us a bit more about the patient.
Okay, thank you very much. So this is a patient from UCL, which was recruited as part of the VIGOR project. Just a little bit of clinical history. She's a 25-year-old lady. She was diagnosed with Crohn's at 19, which is a very typical age. This disease affects people in their youth, in their teenage years, so it can be very devastating for them, a very important time of their life. As is quite typical for Crohn's disease, probably about 80% end up having some form of surgical procedure over the lifetime of their disease. And by the age of 25, she had already undergone one operation to remove the terminal ileum, the last bit of her small bowel. And she presented to her UCH outpatients with very severe iritis, a very severe inflammation in her eyes. And although we're going to concentrate on the bowel manifestations of Crohn's disease today, which is the VIGOR project's all about, there's a whole host of other symptoms patients get in their organs outside their bowel. So one of them is this very severe inflammation in her eyes. She also had pain in her abdomen, which, as we've heard from the video, is a very typical symptom. Her blood tests were normal, which is, as we discussed, the potential benefits of an MR score. That's quite important. Some of the standard tests we use aren't always helpful in these patients. So the gastroenterologist, when she saw her at UCH, was very concerned about her eye condition, and he thought it may be fueled by inflammatory disease in her bowel. So the Crohn's in the bowel may actually make the extra luminal manifestations worse. So he requested a small bowel MRI and a colonoscopy to assess the bowel. So what was going through the gastroenterologist's mind? What were the clinical questions? Well, has the patient got Crohn's disease? Well, the answer to that is yes, but the main question is it back? Has the patient got recurrent disease after the surgical resection has taken away their initial disease? If the answer to that question is yes, and is the disease active? So is there biological inflammation in the bowel which is making her eyes worse, making her feel worse, her abdominal pain? And if there are any diseases in the bowel, is that causing narrowing in the bowel? Is that causing her abdominal pain? Because the bowel is narrowed, there's two options really. You can either increase your medication or you can go in and surgically remove the bowel to try and relieve the patient's symptoms. So going through the hypothesis that the gastroenterologist is thinking when they see this patient, they're thinking, well, if I increase the medication, these expensive, relatively toxic drugs, will that give the patient benefit? Will their symptoms improve? Or is the abdominal pain just rather functional? So it's not due to the Crohn's disease. A lot of people get abdominal pain. We all do intermittently. Is her abdominal pain just because it's one of those things that she's got at the moment, not to do with the Crohn's disease? You don't want to give a patient difficult and expensive and unpleasant drugs if they haven't actually got active disease in their bowel. Or if she has got active disease, or if she has got narrowing in disease, is it actually fibrosis, which is pretty irreversible with our current medication techniques? So she may need a further surgical intervention to control her symptoms. So all these things are going through the clinician's mind when they see a patient come into their clinic with symptoms from Crohn's disease. So in terms of the acquisition, what do we do from the MR? So I won't go into great detail this, I'll just explain a little bit. As we've mentioned, MR is a non-invasive test, so we don't have to put anything into the bowel. We do get the patients to drink something. We have to distend the small bowel to see the bowel wall in any detail so we can assess the parameters that Franz has talked about. Now, one thing that we all know is that Crohn's can affect the large bowel as well as the small bowel. So if you really want a one-stop shop examination using MR, you have to try and get fluid into the large bowel. Now, one way of doing that is to give the patient a water enema. So put a tube in the bottom and put some fluid into the bowel. Again, that will give you good images, but I think it's quite invasive. And as Harry's alluded to, we don't want to have an invasive test that the patients have to undergo, which they don't find particularly pleasant. So for the VIGOR project, we decided not to give the enema technique. We decided to divide our oral bolus into two. So a volume about 3 hours before the MR, with the theory that in 3 hours they'll track through the small bowel and go into the large bowel, so we get some fluid in the large bowel so we can assess that. And then a second drink about an hour before the MR, which fills the small bowel. So in other words, trying to get a non-invasive one-stop shop of looking at both the large and the small bowel. In terms of the sequences, I won't go into the detail about the parameters. There's all in the posters if you're interested, but we do the standard sequences that make up the scoring systems that have been alluded to already. So the Crohn's disease activity score and the Mariah score all rely on a combination of T2 weighted images and dynamic post-contrast T1 weighted images, which we all do. And as part of our clinical correlations for the VIGOR data sets, we collected the Harvey-Bradshaw Index, which is a subjective patient questionnaire score with a few clinical signs as well adapted, which is used quite a lot in the scoring of inflammatory activity in Crohn's disease. We also had a blood test, the CRP, an inflammatory marker, again used quite a lot in the clinic to look at the inflammatory activity of Crohn's disease. And of course, as I've mentioned with the colonoscopy, with the CDEIS has been our gold standard throughout the VIGOR project, and we've made sure that's always within 2 weeks of the MR scan to get very good contemporaneous data. And so we've scanned about 155 patients between AMC and UCH. Not all of those have been eligible for the strict criteria we've got, but we've got a lot of patients' data, as Franz has mentioned, over 3 terabytes, I believe. Harry.
Thank you very much. So I'm taking this patient through a journey in our system. We acquired the images, and the next step is to send the images to the cloud. This is cloud is the word of the moment. It's very trendy. But let me please tell you why we do that. And that was one of our technical visions in this project. We wanted to deploy a cloud platform for this project for 3 reasons, really. We want to be able to share data, so to make it very easy to share data between the researchers. but also to share functionality, the tools that we will develop, but also knowledge, the skills that our people have. And we were hoping that if we do that, we can make collaboration more efficient and faster. And also we are hoping that potentially the results of this project can be commercialized faster. So this is what we wanted to do, and that was our technology vision. So this is an observation that we have in our company. There is a huge amount of knowledge out there for medical imaging globally. So one of the things our company decided to do is to find ways to link this knowledge into an online platform. We call this the global brain of medical imaging, and we've developed this platform to do that. So this is how it works. We would connect to different PAC systems. As a matter of fact, UCL has a different PAC system from AMC. Or we will connect directly to the scanners. And then, using the internet, we will push everything to our data centers. And once they are there, then people, users, can connect to that. And now, be careful, I'm going to say two very critical things. Without installing software, that means that I can open any laptop anywhere on this planet, and as long as I'm connected to the internet and I have an account, I can do what you're about to see. And also the second very important thing is without downloading data. Each VIGOR case is massive. To download it to the laptop, it will take probably 1 hour, depending on the connection you have and all that. So we didn't want to do that. Also, this is very insecure to do that. And this is what we did. And our goals were first to connect the scientists together. Our observation is that one of the main reasons collaborative projects fail is because they don't do that. They don't make it very easy for the experts to work together. But also, we wanted to adopt this model of network-centric innovation to promote innovation faster and better. We wanted to deliver via cloud computing all the archiving tools, the analysis tools, the rendering tools, to everybody with access to them. We wanted to deploy a VIGOR workflow engine, the VIGOR way of moving data between the different scientists. And also, and this is critical for the project, we wanted to provide a very fast and early outlet for the commercialization of the results. So the old system, the without the cloud system, research without the cloud, means that you have to move data between computers, between hospitals, between computers. And once you develop something on the computer, it's very difficult for that something to be used by another person. Whereas with our system, you move the data once from the hospital to the data center, and then it's very easy for the researchers to use it. So this is the main reason we've decided to use this cloud platform. And then we go to the next step of this journey, the annotation. We asked some clinical people in the group to see the images and annotate them using the cloud tools. I would like to please ask Dr. Carl Puylaert, from PhD from AMC, from Amsterdam, to help us and show us how it works.
MRI scan of a Crohn's disease patient. I would like to show you how to extract these features from an MRI scan. For this I will use a few of the sequences that we use. Of course, radiologists will use all of them in this interpretation. Let me zoom in a bit. So here we see the right colon going into the terminal ileum, which is clearly abnormal. And some of the characteristics of Crohn's disease include thickened bowel wall and enhancement on a post-contrast theory. And as you can see here, this is clearly the case. So we can scroll through this. You can here see, for example, a normal bowel wall, which is very thin, and here you see the thickened bowel wall of a disease segment, and I can measure it to make this more clear. We see a thickness of about 11 millimeters compared to a thickness of about 3 millimeters in a healthy segment. Also, we can measure the length of disease, which we also use in the score that we will later present. So we'll do this in a few steps or so. In total, we will see about 10 to 11 centimeters of diseased segment. And also what you can clearly see here, if I zoom in a bit more, is that there's a layered pattern in the bowel wall, which you can see here, which is due to edema in the middle layer, and is also a clear sign of severe Crohn's disease. Then I would like to switch to another sequence, a T2 sequence. And what we can differentiate on this sequence is if we are seeing fibrosis or inflammatory activity. So I'll look up the diseased part, which we see here on the left. Normally, the bowel wall in a T2 sequence will be of a almost black, non-visible shade, but here you can definitely see that it's increased, that it is more of a light gray shade. So this indicates active inflammatory activity, and this is also seen on the post-contrast series. As we look here, we scroll through, we see this, which is known as the Crohn sign, and is also engorgement of the arteries of the mesentery leading up to the bowel, and is also a clear sign of active inflammatory activity in the bowel. For the rest, we don't see any abscess or fistulas. I think that's all we can see in this scan. So I'm very glad to present the automated tools we use.
Okay, thank you very much. And we move to the next step for some serious number crunching. So this is where we take the data and automatically we try to analyze the data and derive a score for the disease. So one of the first problems that we have to address is to define what is bowel and what is no bowel, to segment it. So let me attempt to do that. So one of the things that I might want to start with is to define a center line through the disease part of the bowel. And I don't really need to be accurate. And then, to help the segmentation a bit, I need to define a box. And that's it. I do the analysis. One thing I must say is that the analysis is not happening in this computer right now. It's happening in a cluster of servers somewhere else in London. And here I have the results. I don't know if you can see it in the projector. With green is the inner wall and with red is the outer wall. system automatically computed the average thickness, the maximum thickness, and the length of the most diseased part. Am I going now manually to go and pick the part of the bowel, these abnormalities? And after I do that, I will score. So based on my observations, I will put some markers here. The plan is to automate this step, but right now it's not automated. And the system computes automatically a score for this person. The score is 26.15. It also gives you the other scores for the other ways to score the disease. So what I did is that I went through a tool that automatically segmented the inner and outer goal, and hopefully during the day you will have the chance to listen to some presentations that I will explain how we do that. And after that, we selected some features of the diseased part, and we went through a classification technique for those features. And now we are experimenting with some new ways to visualize those features. I just want to show you this video that was presented in Inventi Berlin that demonstrates exactly the whole processing pipeline. So that's it. This is how we do it, and how we extract a score out of it. And the final score was what it was. But the question is that how good really is this score? How useful is this score? Why this score is better? I would like to invite Professor Taylor again here to explain why this score is better than other scores.
Great, thank you. So this is again building on what Franz was saying in his introduction. So if we go back to the clinical questions we alluded to at the start for this particular patient who was recruited, the questions, to summarise, did they have disease in their bowel, which was driving their abdominal pain, and it was giving their eye symptoms worse? So that's one question we need to answer. And the second one, is this disease active or is it fibrotic? If it's active with biological inflammation, then the treatment paradigm is completely different than if it's fibrotic and fixed, the latter being usual surgical resection, the former being anti-inflammatory medication. So these are the questions the gastroenterologist wants to have answered from any clinical test. And there's many ways he or she may want to do this. There are clinical scoring systems, such as a Crohn's disease activity index. That is where the patient collects their symptoms over 1 week and they mark how much abdominal pain they have, how much diarrhea, for example. And that is added up at the end of the week into a score. The trouble with things like that, although they're very well used in the literature to try and look at therapeutic agents such as new anti-inflammatories, is they're very subjective. A patient with irritable bowel syndrome, for example, with abdominal pain every day would score quite highly on a Crohn's disease activity index. So it doesn't really easily differentiate between those with active disease and those without active disease on an individual patient basis. I mentioned the biochemical markers. So CRP is an inflammatory protein in the blood which is raised in inflammatory conditions. So something like active Crohn's disease will put your CRP up. The trouble is it's non-specific. If you have a pneumonia, you'll put your CRP up. So we don't know it's the Crohn's that's driving it. And there are quite a few patients who don't derive a CRP response when they have active disease. So they can have raging inflammatory disease in their bowel and have a very normal CRP. So again, it's got major limitations. We've alluded to that colonoscopy is probably the gold standard for assessing disease activity. You can look at the mucosa of the bowel directly within a millimetre resolution, look at the ulceration, look at the abnormalities, and really come up with an assessment. But of course, it's not a perfect test. It just looks at the lining of the bowel. It can look at the colon and the terminal ileum in 80-90% of patients, but it won't go beyond that. We can't see the proximal bowel with a colonoscopy. So there's a few good reasons why MR may be potentially not a perfect test, but perhaps an improvement on what we've already got. It visualises the whole bowel wall, not just the mucosa, which endoscopy does, but the whole bowel, so the wall thickening, as well as the extraenteric tissue. So if there's abscesses or fistula or other complications, MR can see that in the images that we provide. We're also not just limited to the large bowel and terminal ileum as colonoscopy is. We can see the whole bowel from the stomach all the way down to the rectum. So there's no limitations in the visualization we can have with MR. And of course, one of the huge advantages for the patients is it's much less invasive than colonoscopy. Colonoscopy is a difficult test. Patients have to have a difficult bowel preparation. They have to have often painkillers while they have the procedure. It's invasive to put this endoscope around their bowel. And of course, they don't really want to come back and have that done on a regular basis. And as we've alluded to, there are now increasingly validated MR biomarkers of activity. So you've seen how we look at the wall thickness, the contrast enhancement, and the pattern of that. And all these can be quantified into the various MR scoring systems, which we've mentioned. So the MR scoring systems we've been using, which Harry presented there, the AIS or London score and the Maria score, are both in the literature being validated against histology and endoscopic scores. But as you can see, they're quite time consuming, they're quite subjective. So if I look at a bit of bowel and score it for the T2 signal, I may not be given the same score as another radiologist sitting next to me. So there's a definite subjectivity within the scores. And so there's clear ways we can try and improve them. This is where the VIGOR project tried to meet this challenge. Can we automate many of the factors that we score with the MR systems into a time-efficient and robust way of looking at the various parameters that we look at? So I'm going to pass on to Peter now as to how we may be improving on the MR scores we already have.
Thank you, Stuart. So as you have heard before from Fran's talk, that we developed the score in an exhaustive search approach. We tried all combinations of features, and in the most recent version we stick for these features, top 5 features that we found most important for CDIS prediction. We made this linear regression models to predict the CDIS score, and we found our score to have a superior performance or correlation to the CDIS score than the other reference models. For example, on a retrospective data set of 30 patients, we make a cross-validation and we see that the median correlation is around 70% with our best model on our data set, which compares better than Maria's score in red or the CDA model in orange. Also on our prospective data set, which we acquire in this VIGOR project, we have now 35 patients acquired, and we see also that our score has a good validation on this data set. And the difference between the Maria score and our VIGOR score is also around 20% in the validation set and also in the prospective data set. Okay. Yeah.
Thank you. Thank you. So that was it. What's next? What is next for VIGOR? What is the next step? We are very keen to build on the foundations and maybe one day work in achieving that dream of the thermometer for Crohn's disease. What we would like to do is to explore better the value proposition. And you will have a presentation later that will tell you all about it. What is the value of this tool to doctors, to radiologists, to gastroenterologists? What is the value of this tool to health systems, to the NHS? But also at the end of the day, what is the value of that tool to Barbara or any Barbara? How she can use it to manage her disease better? So yes, we would like to streamline the process, the technologies, make it more automated, faster, better. But this is not really the big question. The big question is what value we deliver to the different stakeholders. And this is what we would like to explore as the next step. Thank you very much. I have one more thing. And since we have 5 minutes, I just wanted to play this song. This song that you will have in a minute is composed and performed by a young lady who has Crohn's disease and talks about her experience. And this is, at the end of the day, what one thing that I want you to remember out of that. The technologies are cool, but what we have to do is to see how we can apply technologies for the benefit of people like Barbara or her.
I'm a little girl lost in this big, big world, running away from my pain, trying so hard to escape. Hold my rebel, help me float away. It will all be over soon. Dance with me tonight, or I'm in a circle of my life. Follow me through that train. I'll show you what it's like being me. Look at me straight
please do visit our website, vigorpp.eu. Thank you.
Great.